I remember a story. I remember an incident where a professor of medicine came to the class and said, if you want to be a good doctor, you need to have two qualities. One, you should be able to work in a difficult situation, and two, you need to have a keen observation. In order to prove his point, he brought into the class a stinky liquid, extremely stinky, disgusting, you just can't go near that, and asked the students, can anyone dip your finger in it and suck it? Everyone hesitated, but the professor dipped his finger and sucked it. And he asked why any of the students are they capable of doing it. It was such a stinky one, bad in color and so disgusting, so nobody came forward. At last, one courageous student came forward and said, I can't do it, sir. And he dipped his finger and then sucked it. Then the professor said, young man, you have passed the first test. That means you are capable of working in an extremely difficult situation. But in the second one, you have failed miserably. You did not observe that the finger that I dipped in was not the finger that I sucked. So you need to develop a keen observation in evaluation of the fetus, especially in a TIFFA scan. So what you are seeing here is a axial section of the head. But if you look carefully, you can see the cavum septum pellucidum is absent in these sections, and with the mild dilatation of one of the occipital horns of one of the ventricles. And in this section you can see that the cavum septum pellucidum is absent. This is case of agenesis of corpus callosum, which finally lead to the diagnosis by karyotoping of an chromosomally abnormal fetus. This is another case that came at 28 weeks of pregnancy with polyhydramnios and mild symmetric iugia. Structurally everything was normal in a routine scan, but when we did a TIFFA scan, especially a 4D targeted scan, what we found was the foot was showing an abnormal shape. This is something called as a rocker bottom foot. And the the fetus was showing the finger in this position, that is clenched fist with overlapping index finger throughout the period of study. We repeated the examination at different intervals and found that the baby was keeping the fixed position of the hand and the foot was showing a rocker bottom foot. If you put both these things together with the polyhydramnios and symmetric iugia, what would be the diagnosis? This was a case of trisomy 18, which was proved by chordosynthesis and karyotyping later. In this case, is the image on the left side normal? If you see an abdominal circumference section, this is how the normal AC section will be. The stomach bubble here and the umbilical vein turning into the right portal vein. Actually the portal vein is directed away from the stomach. But if you look at the section here, this umbilical vein is turning to the side of the stomach. This is a classical case of persistent right umbilical vein. Why is it important? 80% may not be associated with any anomalies, but there is a possible association with cardiac, renal, limb defects and chromosomal abnormalities. So once you see an abnormality like a persistent right umbilical vein, that's the umbilical vein turning towards the stomach, you need to do a thorough scan, a TIFFA scan to evaluate for anomalies in the heart, kidneys or the limbs. The high abdominal views in fetal echo is extremely important. The fetal aorta, thoracic aorta on the left side, the confluence of hepatic veins and the IVC on the right side. Ideally, you don't see any vessel between the aorta and the IVC. If you see any vessel between them, that suggests you the possibility of a total anomalous pulmonary venous connection especially of the infradiaphragmatic type. So looking into the high abdominal view, if you see any vessel between the aorta and IVC, that is the only clue that you can get in cases of total anomalous pulmonary venous connection, especially the infradiaphragmatic type. This is a case of supracardiac type of total anomalous pulmonary venous connection. This is a case-based review, a 20-week scan that showed a small head, the fetal stomach bubble and heart in the same section. It's a diaphragmatic hernia. And if you look at the hands, you can see 6 fingers. It's a polydactyly. And in this section, if they evaluate the fetal head, you can see there is a single ventricle, fused thalami, the fetal spine showing an open spina bifida with meningomyelocele, and the fetal forehead showing a echogenic protruding focus, and that was a proboscis, and everything put together, multiple congenital anomalies, especially the proboscis and holoprosencephaly, polydactyly put together. This turned out to be a trisomy 13. This is a proboscis, the single orbit, single eye, absent nose, the meningomyelocele and open spina bifida, the polydactyly here, and this is a trisomy 13, the chromosomally abnormal baby. Again, the importance of looking for subtle anomalies. If you see this head section here, you can make out that there is bifrontal scalloping here. This is a classical lemon sign with hydrocephalus. The moment you see this, you need to look for the spine, and you will see an open spina bifida with a meningomyelocele. It may be as obvious as this one. With the 3D section, it is being shown very clearly. Another case were a bilateral mild hydronephrosis of pylectasis. This can be a clue for posterior urethral valve, or can be a minor marker for chromosomal anomalies, especially trisomy 21. Now, in a TIFFA scan, we have already discussed the importance of organ-specific evaluation of the fetal CNS, the cardiovascular system, the musculoskeletal evaluation, the facial evaluation, the fetal KUB, and the evaluation of the genetic markers. Apart from that, we have already discussed the importance of looking for subtle lesions which can lead to give you vital clues about the serious abnormality. It's also possible to do a functional evaluation of different organs of the fetus. A bladder emptying is a good sign. An unduly distended bladder which is not emptying may be a clue towards a posterior urethral valve. A gastric emptying is another clue. Complex motor movements, swallowing, the nasal fluid flow, the cardiac rate and rhythm, these are the functional markers which can be evaluated, and if there is any abnormality related to that, it may give us some vital clues regarding an organ dysfunction. Apart from all these things, you need to evaluate for the fetal environment. The placenta, the umbilical cord, the liquor, the uterine, and the fetal blood flow. So many a times when we see a limb shortening, it may not be always a skeletal dysplasia. It can be a severe iugia. Another point that I would like to make with regard to TIFFA, or the targeted imaging for fetal anomalies, is the importance of serial evaluation. You need to evaluate a fetus at 3 different intervals. 1, 11 to 14 weeks. 2, 18 to 20 weeks. And the last one is the 32 weeks. These 3 are specific for anomaly evaluation. The popular concept of doing a single anomaly scan may be catastrophic in some cases, especially 20-week scan absolutely normal. In 32-week scan, you discover that a severe hydrocephalus. How can it happen? Maybe a verminagenesis that was manifested later, or a corpus callosum agenesis that was manifested later, or even a destructive process leading to a porencephaly which can happen later. So evaluation at different intervals is extremely important. And there are certain anomalies which may manifest later. So these are some of the examples of that, like aqueductal stenosis, verminogenesis, a tetralogy of Fallot, which become manifest, or a coarctation, and achondroplasia. And achondroplasia starts manifesting after 20-22 weeks. The difference, the limb shortening becomes more and more obvious only after that period. So if you do an evaluation at 18 weeks and say that the baby is absolutely normal, you may be in for a surprise at a later period. Diaphragmatic hernia or eventurations and urinary tract obstructions and reflux. So this tells you the importance of doing a serial evaluation. The denominator or the point that you need to understand is that fetal growth is a dynamic process. So coming to the indications of targeted imaging for fetal anomaly, the TIFFA scan. Any abnormality on routine scan has to be subjected for a detailed evaluation. Previous congenital abnormality, it is always better to go for a TIFFA scan. Babies of diabetic mothers, and especially in multiple pregnancies, in IUGR, intrauterine growth restrictions, or abnormal nuchal translucency or GS to CRL disproportions, all these are indications for targeted imaging for fetal anomalies. But if you look at from the point of the parents who want a reassurance from you that this baby is structurally alright, ideally I feel all babies deserve a targeted imaging for fetal anomalies. So ideally all babies deserve a TIFFA scan. Thank you.